Hello all. So today we are going to discuss on previous year questions. We are moving to the questions in the year 2023. Features of hyperparathyroidism in a young boy. What is the next line of investigation? USG in neck, X-ray bilateral radius and spine, PET scan and DEXA scan. Obviously USG neck. So hyperparathyroidism in young boy, we are probably looking at primary hyperparathyroidism, right? So USG will be the basic investigation. So like I said, ultrasound neck will be the basic investigation of choice. Why? It is non-invasive, inexpensive, and once you have a suspicion of parathyroid adenoma, then you can obviously have a confirmation with sesame B scan. Okay, so parathyroid adenomas, they are oval or elongated hypoechoic structures on the ultrasound. They rarely can be cystic or heterogeneous. Like I have mentioned before, giant adenomas are the one where the size is more than 3 centimeters. Okay, but the downside of an ultrasound is it is operator dependent, lesion dependent. Like if the size is very small, ultrasound may not be the investigation of choice, and obviously if it is retroesophageal or retrosternal, then again ultrasound may not be the appropriate one. X-ray bilateral radius and spine, obviously it does detect skeletal changes, but it does not help us in locating the parathyroid adenoma. PET scan, again, it's expensive, it is not routine, it is reserved for special cases. DEXA scan, it assesses bone mineral density, hence it is not for diagnostic of a parathyroid adenoma. Next, what is the most common complication following total thyroidectomy? Hemorrhage, recurrent laryngeal nerve palsy, hypocalcemia and wound infection. Correct answer is hypocalcemia. It is the most common one where there is accidental injury or removal. Sometimes even a phenomenon called stunning can lead to hypocalcemia. What are the symptoms? There will be tingling or numbness. So that is peroral and peripheral. Okay, muscle cramps or spasms, that is tetany. Severe cases may lead to seizures if it is untreated. Permanent hypocalcemia is obviously less common, but if it does occur, it is devastating because it will require long-term, lifelong calcium and vitamin D supplementation. So hemorrhage, although it is one of the documented complications, nowadays due to better surgical tools, the incidence of hemorrhage is low. Recurrent laryngeal palsy, again, in hands of an experienced surgeon, the chances of RLN injury is also low, and that too permanent is very, very less. Wound infection, due to good rich blood supply in the neck, the chances of wound infections are low. Next question, a 30-year-old male with zone 2 neck injury and a 2 centimeter disruption of CCA. What is the best management? Ligation, A, venous interposition graft, B, ligation and subclavian artery carotid bypass, ligation of CCA and sympathetic chain block, repair. So the best option here would be venous interposition graft. I have already told you about 3 zones of injury, where it is zone 1 from thoracic inlet to cricoid cartilage, zone 2 cricoid cartilage to angle of mandible, zone 3 angle of mandible to base of skull. So what are the signs of neck trauma? Subcutaneous emphysema, air bubbling from penetrating wound, expanding neck hematoma, hoarseness of voice. Why the others are incorrect is ligation is reserved for cases where primary repair or grafting is not feasible. Okay, and simple repair, although is an option, it is not for a defect which is more than 1 centimeter. So this brings us to the end of discussion of the previous year questions. Thank you.